Welcome everyone. Thank you for being here today. My name is Maddie Morales, and I am part of the team working on the Life Unites Us campaign to reduce stigma around opioid use disorder. So today we will be recording this video just so you all are aware, and we will be sharing the presentation afterwards, so it will be recorded. So my role in this effort is to figure out how we can connect our efforts with you and your organizations. And so we'd love to sort of learn a little bit about who is on the call today. And a quick housekeeping note: if you have questions throughout the presentation, please add them to the Q&A function at the bottom of the webinar. And then the chat function is for any introduction. So we'd love for you to drop your name in there and your organization, or maybe how you heard about this event into the chat message. But if you have specific questions that you want the presenters to touch on, please put that in the Q&A section so we don't miss it. But first, to get things started and to learn a little bit more about who's on the call today, we have a quick poll with two questions. The first question is, what part of Pennsylvania are you located in? So tell us where you're coming from. And we would also love to know what best describes your organization or affiliation. So if any of those describe where you're coming from, please let us know. And if there's something that's not represented there, feel free to add it in the chat so that we know who you are. Welcome everyone. I see you putting all of your names into the chat. Welcome. It's great to see some familiar names and lots of new ones. So welcome. All right, so it looks like we've got people from all over the state. Pretty awesome. And lots of nonprofit workers, welcome. So for those of you who do not know about, or for whoever this is, they're just learning about the Life Unites Us campaign for the first time, I just wanted to share a couple quick notes about this project. So Life Unites Us is a campaign developed to reduce stigma around opioid use disorder. And we do this by sharing, let me see if my slides are working. They are. So we do, the Life Unites Us, we do this by using a people-forward approach that aims to connect individuals through stories. And we do this because through research and practice in anti-stigma work, we have found that connecting people through their stories and similarities can and will reduce stigma. So the way that we do this with Life Unites Us is that our team records stories of community members across Pennsylvania, both stories of personal recovery or as an ally to someone who is in recovery. And we then produce these short videos on our website and social media to be shared far and wide across social media platforms. And our intent is that by sharing these stories of hope and resiliency, we can prove that recovery is possible. Reducing stigma makes recovery more likely. Addiction is treatable. Those living with an addiction are just like everyone else, and those living with an opioid use disorder are so much more than their disease. This campaign can be found online. So we are, and we have a website with a library of stories and resources that we share across different social media platforms, Twitter, Facebook, and Instagram. And we invite you to check those out and join, follow, share, like, comment, all the things. We love to hear from you. And we, in order to make this happen, we work alongside the Pennsylvania Department of Drug and Alcohol Programs, Shatterproof, and Penn State Harrisburg. And if you're interested in getting more involved, we recognize that our efforts are really nothing if we don't have the support of the community and support of individuals and advocates like all of you on the call today. So we'd really love to be in touch with you and work together to get these stories out to the communities that need and want to hear them, and also to uplift stories in your communities that you want to hear. So let us know if you want to get involved. That's my email, madelinemorales@publicgoodprojects.org, or info@lifeunitesus.com. So without further ado, I think the reason why you all are actually here today is to talk about language and stigma and how language affects stigma. So we have two guest speakers here today, Dr. John Kelly and Matthew Stefanko from Shatterproof. So first up, we have Dr. John Kelly, and he is the Elizabeth R. Spalin Professor of Psychiatry and Addiction Medicine at Harvard Medical School. He's also the founder and director of the Recovery Research Institute at the Mass General Hospital. He's the associate director of the Center for Addiction Medicine at MGH. And Dr. Kelly is a former president of the American Psychological Association's Society of Addiction Psychology. He's also a fellow of the APA and a diplomat of the American Board of Professional Psychology. He's served as a consultant to the US federal agencies and non-federal institutions, as well as foreign governments and the UN. Dr. Kelly has published over 200 peer-reviewed articles, reviews, chapters, and books in the field of addiction medicine, and was an author on the US Surgeon General's report on alcohol, drugs, and health. So we have quite an expert here, really excited to hear from him. And I also just quickly wanted to introduce Matthew. He's the director of National Stigma Initiative for Shatterproof. But before joining Shatterproof, Matthew was the associate director for strategy and programs at Planned Parenthood Federation of America. There, he worked across functions to develop strategic initiatives aimed at increasing patient access and reducing the impact of health epidemics. Matthew also previously worked in local government at the Baltimore City Health Department, where he supported Dr. Leana Wen as her special advisor on opioid policy. And Matthew has a dual degree in economics and government from Cornell University. He serves on the board of Annabelle's Grocery, a nonprofit store addressing food insecurity, which he also co-founded. So some star performers here that are going to share some information with you. So we will start with Dr. John Kelly. Thank you.
Great, thanks, Maddie. Hope you can hear me okay. Great to be here. Great to be here with Matthew. Thanks for the opportunity. Now, are you going to forward my slides, or can I do that?
Yes, I can push them forward for you.
Okay, great. All right. Well, thank you. And thanks for the, like I said, the invitation and opportunity. Great to be here with you all. I hope that, what we've got to talk about today will be at least interesting, if not helpful and informative to you in your work as you go about your work. This is an area, of course, of great importance to our field of addiction, substance use disorders, addiction medicine, just because whenever we talk about drugs, alcohol and drugs, we are talking about stigma. We're talking about stigma and discrimination because, as I'll explain, these are among, if not the top most stigmatized conditions in most societies around the world. So I'm really grateful for the opportunity to talk to you about this. I don't have any disclosures. Next slide. So, it's interesting just zooming out a little bit, thinking about the last 50 years, because we're actually at a 50-year milestone since the declaration of the war on drugs under President Nixon. And really what that did was it marked a concerted federal effort, both in terms of kind of what we normally associate with the war on drugs, which is kind of the more harsh, tough on crime approach to do with interdiction, reductions in supply, et cetera, but also marked an investment by the federal government in new institutes. That includes the National Institute of Alcohol Abuse and Alcoholism, which was founded in 1970, the National Institute of Drug Abuse, which was founded in 1974, and SAMHSA in 1992. So all of these federal institutions came about as a result of this federal investment in addressing, quote, the drug problem. Next slide. What's really happened in the last 50 years is a market shift in the way that we approach and address these endemic problems. Nixon famously declared drug abuse, quote unquote, drug abuse as public enemy #1. And you can watch YouTube videos of him doing that right now on YouTube. Don't go there right now, of course, because you're watching this. But at some point after this, you can go and check President Nixon out describing this. But the idea, of course, and the fear was all the Vietnam vets coming back from Vietnam, who had been exposed to opioids over there will be coming back, and there'll be a huge epidemic of opioid addiction. This was the fear. And so there was this big concerted effort back in the 70s to address this, what they foresaw as a big problem. But if you think about what's happened in the last 50 years, there's been a number of different changes. I think one of them has been in the way that we conceive and approach these endemic problems. Think about how we even talk about these problems today. We don't talk about it as public enemy number one, but we do talk about it as our top public health problem. Next slide. So it's still the top problem. It's just that we've shifted in our emphasis, our relative emphasis, in the way that we frame these problems, conceptualize how best to address them. This is because our language both reflects and affects how we approach these problems. Look at the laws that have been passed, the major laws that have been passed in the last 50 years. They reflect this change from the harsh punitive laws, the Anti-Drug Abuse Act, the being tough on crime, the mandatory minimum sentences, etc., which saw prison populations burgeon around the country, to the Mental Health Parity and Addiction Equity Act, to the Affordable Care Act, to the CARA, the Comprehensive Addiction and Recovery Act. All these acts really were for the provision of access to care and parity for care for substance use disorders. Next slide. So these shifts really have happened, next slide, in the last 50 years. I was privileged to be at this first ever National Drug Policy Reform Summit held at the White House in 2013. And this really marked a federal shift away from the war on drugs towards a broader public health approach. And I was actually invited to present some of the data that I'd been working on, studies I'd been doing, looking at stigma, discrimination, and language. Next slide. Now here's another shift. Look at this. I was at the United Nations representing the US back in January last year. And we were talking about stigma and discrimination against people with drug problems worldwide. When I stepped outside, this monument on the right-hand side was the only monument that was present outside the United Nations building in Vienna. And you see what it says there? It says, dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. So you can see these shifts that are occurring both nationally, internationally. Next slide. Think about what's happened also in terms of our criminal justice approaches, the birth of drug courts, the idea that many crimes are driven by compulsive drug use. And if we can address the root of these problems through providing proper treatment for people who end up, unfortunately, in the criminal justice system, we might be able to better and more effectively address crime through addressing the root of these problems. Next slide, which is addiction. Some of you may know this person. It's Chief Campanello. He's from Gloucester, Massachusetts. He made headline news a number of years ago for recognizing that people with addiction problems, rather than be criminalized, but rather to be treated. And so he started this program called the Angel Program, saying that publicly, if you come to our police station, we are going to take you to treatment, not to jail. We're not going to arrest you. We're going to get you the treatment that you need. Now, imagine that 20, 30 years ago, a police chief, this is a frontline police chief, making national headline news for addressing what he saw as a crisis, in this case, opioid addiction, but addressing it not through criminal justice, but through treatment. Next slide. So a number of different changes have occurred in the last 50 years. I wanted to kind of just give you a quick review of that because I think it's significant when we zoom out and think about really how far we've come. We've got a long way to go, that's for sure, but we have made some shifts in the way that we think about, conceptualize, and talk about these endemic problems. So the heart I'm going to talk about today is stigma and discrimination and what we can do about it. So what is stigma? Stigma, you can define it as an attribute, a behavior, or condition that is socially discrediting. What's discrimination? Next slide. Discrimination is the unfair treatment of people who have that particular stigmatized condition. So it's good to make the distinction, I think, between the stigmatized condition and the treatment of those with that stigmatized condition, because really what we're talking about is discrimination of people who have that condition, in this case, substance use disorders. Next slide. Now, stigma, when it's looked at, when we think about stigma, there's both public and personal stigma. And there are many consequences, of course, to stigma. For example, public stigma can lead to differential public and political support for treatment policies or criminal justice preferences. It can also erect barriers to employment or remove those barriers to employment, training, and education. It can also erect barriers or reduce barriers to housing and other kinds of perceptions. What about personally? Stigma can also increase personal shame and guilt from having the condition. It can delay seeking help or prevent people from seeking help. And it can increase the chances that they'll drop out from treatment if they do get treatment. Next slide. And these are the commonly studied dimensions of stigma. Blame. This has to do with, are they responsible for causing their condition or problem or disorder? Did they cause it, or are they a victim? Prognostic optimism has to do with, are people who have the condition, can they get well from it? Can they recover from it and be, quote unquote, like normal people? Are they dangerous who have the condition? And related to that, do they need to be ostracized, or would you have them would you employ them as a babysitter, or would you share an apartment with them, or have them marry into your family, for example? And these are commonly studied dimensions of stigma. Next slide. Turns out substance use disorder, I alluded to this earlier, but when you look both nationally and internationally across different societies, this tends to be the top of the list in terms of stigmatized conditions, particularly illicit drug use disorders, and particularly heroin and cocaine, particularly crack cocaine. These tend to be the most stigmatized. But this was a study done by the World Health Organization across 18 of the most stigmatized conditions in 14 different countries. And guess what? Every single country ranked #1, illicit drug addiction as the most stigmatized problem. Alcohol addiction, #4 in this list of 18. So think about that. This list included things like being a criminal, being HIV positive, all the kind of stigmatized conditions that would be on this list. These ones top of the list, particularly illicit drug addiction. Next slide. Other studies have also shown that substance use disorder, compared to other kinds of psychiatric illnesses, are more stigmatized. In part because people are perceived as more to blame for having their condition. And again, why is that? Well, because it involves some element of choice, right? You have to imbibe the substance in order to get the disorder. You have to expose your brain over and over again. Now, there are genetic modulators, which of course increase risk for that repetition of exposure. We'll talk about that in a minute. Describing substance use disorder as treatable helps. So we heard at the beginning that addiction, substance use disorder is treatable. Most people actually achieve full sustained remission. A lot of people don't know that. Patients themselves who hold more stigmatizing beliefs are less likely to seek treatment or seek it sooner and discontinue sooner, And also clinicians, physicians and clinicians, just like the general public, are shown to have stigmatizing biases against people with substance use disorders. They tend to view them as unmotivated, manipulative, dishonest, the kinds of adjectives we wouldn't apply to other areas of medicine. But the good news is that there's things that we can do about it, particularly with clinicians, by way of educating clinicians about the nature of these conditions. In fact, those in the mental health field tend to have less stigmatizing attitudes, and those who work in addictions tend to have even lower, as you might and hope that people who are working with people with these conditions tend to have the lowest stigmatizing attitudes towards them. Next slide. So why is addiction so stigmatized compared to other social problems and health conditions and other mental illnesses? Well, I've alluded to that a little bit already. Next slide. I think there's two factors which influence stigma, and they have to do with cause and controllability. And we've learned a lot about these factors as they pertain to addiction in the last 50 years from all the research that's been pumped out of NIDA and NIAAA. But if you think about it, why is it that substance use disorders are stigmatized? Now, think about these two dimensions, cause and controllability. In general, when we say about a condition or a problem or a disorder that it's not their fault and they cannot help it, stigma tends to decrease, right? Now, on the other hand, if you say, well, no, it is their fault, they did cause it, and they really can help it, they really can control their use if they want to, therefore, and stigma tends to increase because people are presumed to be engaging in willful misconduct. Next slide. And this just shows the relationship between those two dimensions. Next slide. Now, as I alluded to just now, we've learned a lot in the last 50 years from all the research that's been produced by the National Institutes of Health. We understand much more clearly, for example, that addiction is, like many other complex illnesses, is what we call a complex illness. And a large part of the risk for addiction is conferred by genetics. Roughly half the risk for addiction is conferred by genetics. This is responsible for what I alluded to in that initial exposure. Some people, when they're exposed to a drug, they don't even realize this, but they're more susceptible to the rewarding properties of that drug. So when people drink alcohol, for example, which is the most common type of addiction, some people get a more profound response to the exposure to alcohol than other people, and they want to repeat it. And they also metabolize it differently, so they have to drink more to get the same effect. And so this can set people up for the progression of greater exposure, which can change the brain and lead to addiction. And this is how genetics influence the risk. Next slide. That's in terms of cause. What about in terms of controllability, the other dimension that affects stigma? Mention those two dimensions, right? So controllability, we understand now much more clearly. Think about all the brain images we've been shown over the last 25 years. Now we have a much clearer understanding of how exposure to drugs, whatever the drug may be, changes the brain, the structure, in terms of the neurobiology, the function and the structure, both in terms of reward, memory, motivation, impulse control, and judgment. These particular neurocircuits shown here, which affect our ability to regulate the impulses to use drugs despite harmful consequences. This is what we know as addiction. Next slide. Not just functionally, but structurally. If you look down the bottom right-hand side, you don't have to look very long or very hard to see a big difference between someone with chronic alcohol exposure versus to someone who is a moderate drinker. There is a structural difference in the brain that occurs over time, which is not hard to see. This is perhaps why helps us understand why it is that somebody who has the capacity that Mother Nature has endowed for 80 years roughly of life can literally poison itself, an organism can poison itself to death roughly 30 years on average earlier than Mother Nature intended. There is a medical malfunction which goes on in the brain, which causes this premature mortality and this dysregulation in impulse control. Next slide. So what can we do about stigma? Education is one way, right? So when we see images, when we understand both the causal factors and the controllability factors, we've learned a lot from genetics, from neurobiology, about how our brains change, how we're placed at risk, some of us through our genes, like other complex illnesses. That is helpful because we do know that clinicians, for example, who are more educated around these issues tend to have reduced stigma. Another way is personal witness. This has been a major thrust, of course, in the last 15 years with Faces and Voices of Recovery and other organizations putting a face and a voice on recovery. Why is that important? Because it tends to dismantle publicly held stereotypes about what someone with an addiction problem looks like and talks like and acts like. And so being able to talk openly about recovery status as a person in recovery has helped because it's helping to dismantle those stereotypes. Another way that we can change is through our language, as I mentioned, and terminology, because that not just reflects, but affects how we address these problems. Next slide. So I've talked a little bit about the genetics and controllability. So what happens to stigma when we emphasize this? It's not as straightforward as we think. Next slide. So what happens if we emphasize, for example, the biogenetic aspects, the causal aspects? What happens to those elements of stigma, like blame and social distance and dangerousness, and the belief that somebody can get well? Well, here was a big meta-analysis that was conducted, where they had 28 studies where they looked at different studies that increase the perception of the genetic effects of causal effects on, this is actually mental illness, not addiction. Okay, this is mental illnesses other than addiction. What they found was that when they increased the perceptions of genetic influence on mental illness, it did actually reduce blame. It did reduce personal blame, the stigma associated with that. But here's the kicker. It actually increased social distance. It increased perceived dangerousness, and it increased the perception that people could not get well from that particular mental health condition. Interesting. So it reduced some elements of stigma, but increased others. Next slide. What about controllability, that other dimension? What would happen if we emphasize the neurobiological changes that go on in the brain? What happens to those elements of stigma then? Well, again, this is a mental illness in general, not addiction specific. But interestingly, what they found was that when the neurobiological aspects of these illnesses were mentioned and emphasized, actually all of those aspects of stigma increased: social distance, dangerousness, and prognostic pessimism. People thought that you could not get well if you had a chronically relapsing brain disease, and it had no effect on reducing blame. Next slide. So what about in the addiction world? We just finished this study. We've just published it. So this is a big nationally representative study where we looked at this in addiction, looking at with addiction-specific terminology. Next slide. So we contrasted these different ways of describing someone with an opioid use problem, opioid-related impairment. And people were randomly assigned to receive a vignette that described someone with opioid impairment, but used one of these 6 different terms. It described the impairment as being a chronically relapsing brain disease, as being a brain disease, as being a disease, an illness, a disorder, or a problem. So at random, people were exposed to one of these terms embedded in a vignette which described someone in treatment with opioid-related impairment. The vignettes were identical except for these terms. Next slide. Next slide. Interestingly, we found the same kinds of results as what was found in those other meta-analyses. Look at the top slide. For example, when we emphasized, when people at random got the vignette describing the person as having a chronically relapsing brain disease, as opposed to those other ways of describing the disorder, the blame attributed to the person was substantially decreased. On the other hand, look at the other end of that spectrum, where the person is describing as having an opioid problem. That was associated with an increase in stigmatized blame. So to blame them more for having an opioid problem, but blame them less for having a chronically relapsing brain disease related to their opioid disorder. But now look at the bottom graph. The exact opposite was true when you looked at the perceptions about the optimism, the likelihood of that person recovering. If you describe the person as having a chronically relapsing brain disease, you substantially reduced the perception that they could recover. On the other hand, look at the problem. If you describe the person as having an opioid problem, the perception that they could recover and were less dangerous and were more likely to be accepted into society, all those increased. Interesting. So it depends. In other words, it depends on what kind of stigma you want to decrease and you see how the terms co-vary with those particular stigma. Next slide. Next slide. So these kind of paradoxical nuance findings on biological explanations it really means that we have to be more thoughtful about how we talk about these problems. And it may mean that it depends on our communication. When we want to reduce blame, perhaps in clinical settings, we might want to use more medical terminology. When we want to increase optimism in the general public that people can recover, that they're not dangerous, that they can be accepted and welcomed into society as they should be, and that they're eligible for any kinds of activities that other people might experience. We might want to use non-medical terminology such as problem. Next slide. So what about language? So we have, next slide, we have a lot of different terms. Next slide. That we use in the addiction field, right? Next slide. Not just in terms of the disorder, but how we, as I mentioned already, how we describe it, but people who have the disorder as well. Next slide. And this has been a major thrust of what we've been doing to change our language in the field. And this has happened, as I mentioned, in broad stroke terms, but also in more fine-grained terms, in terms of the actual terminology that we use. Let me ask you this question real quick. People with, how we do for time? We're okay. So people with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers or drug abusers and not as having a substance use disorder? Right? We never refer to people with eating-related conditions as being food abusers. They're always referred to as having an eating disorder, as people working in the eating disorders field. That just comes natural. We're used to saying that. But interestingly, we were used to calling people with these problems with substances, drug abusers, alcohol abusers, substance abusers, and not as having a substance use disorder. Now, part of that is just habit, but of course, habits derive, or linguistic habits derive from culture. Next slide. Question is, does it make any difference? And this is the question that I asked many years ago now. Does it actually make any difference whether we call someone a drug abuser or we refer to them as having a substance use disorder? Is it just political correctness, semantics? Next slide. We did a couple of studies where we actually randomly assigned, like I did in this other study I just talked about, we randomly assigned a vignette describing a person in one of two different ways, either as being a substance abuser or as having a substance use disorder. Otherwise, the vignettes were identical. And these were randomized to a large sample of clinicians. These were doctoral level mental health and addiction clinicians. Next slide. And half these clinicians got the vignette describing Mr. Williams as being a substance abuser, and half of them got the vignette with him being described as having a substance use disorder, as otherwise they were identical. And they were asked to rate Mr. Williams on a number of different stigma-related indices. What did we find? Next slide. Turns out those at random, and these were doctoral level clinicians, at random who were exposed to the person described as a substance abuser, were more likely to view that person as to blame and less in need of treatment, more in need of punishment. Next slide. When we did this same study or a similar study with the general population, we found even bigger differences. Next slide. This is comparing a substance abuser versus someone described as a substance use disorder. You can see here that the person described, which is the dark blue bar, described as having a substance use disorder, were perceived to be more in need of treatment, less in need of punishment, less of a social threat, less to blame, more likely to be exonerated, and less likely to be able to self-regulate. In other words, they weren't engaging in willful misconduct, but rather they were acting out of the compulsion to use despite harmful consequences, what we typically classify as addiction. But those differences you can see there, those are not significant. There were substantial magnitude differences in terms of the effect of describing someone as a substance abuser versus having a substance use disorder. Next slide. So if you think about what that means, it means that even among well-trained clinicians, they are susceptible, even when they don't mean it themselves, and even when we don't mean it when we use that terminology. We may induce inadvertently that implicit cognition that judges those same individuals more punitively, more harshly, more to blame, more dangerous, less deserving of help than if we were to use a term like substance use disorder or person-centered language. Next slide. We wrote a paper also just looking at this issue of dirty and clean. We don't use, I heard one of my colleagues at arguably one of the top 5 hospitals in the country where I work, describing people's urine toxicology results as being dirty and clean. We don't use that terminology in any other area of psychiatry or medicine. Why do we use it in public health and clinical settings to do with this disorder? So again, I don't think we need a study to show that dirty and clean is not good terminology to be using in clinical and public health settings. Next slide. Now, we've tried to change this gladly. I'm happy to say that there's been a lot of change. Matthew and Shatterproof have been doing a great job advocating for these changes, but there's been a wholesale change. It's changing now to try and change our language. We published this a dictionary, which is housed at the Recovery Research Institute website, recoveryanswers.org, in an attempt to destigmatize by unifying our language and through creating a common vernacular with standardized terminology that we can all use to help us get on the same page, literally, in terms of how we address and talk about these problems. Next slide. And this has been changing all around the world. Google adopted the dictionary in Recovery Month and featured it in Recovery Month last 2 years. Thank you, Google. Next slide. Next slide. American Bar Association, attorneys, Attorney Association for Certifying Attorneys have adopted the dictionary. Again, trying to change the way that we talk about these problems and conditions of people who suffer from them. Next slide. The International Society of Addiction Journal editors. No more can you publish across the science internationally using terminology like drug abuser, substance abuser, etc. that is considered to be stigmatizing. You can't publish that anymore. If we don't publish that stuff, if we don't see it in print, if we don't hear it, we're less likely to use it. Next slide. And there's been all kinds of societies around the world that have adopted this now. Next slide. So again, what do we do? How do we talk about this? And people with these problems, these conditions. Again, just it's habit. Our language is habit. It becomes automated over time. Just like we talk about eating disorders and people with eating disorders and working in the eating disorders field, we don't think about having to say that. It's natural, it's habitual. And we can get into the same habits. It takes a little bit of practice, but after you've stopped yourself from calling someone a drug abuser or an alcohol abuser or alcohol abuse or drug abuse or heroin abuse, you can start to refer to them as individuals, as persons, as people with that particular disorder. The mental health field have already done this many decades ago, started this initiative. We are catching up in the addiction field. Again, with urine toxicology results, not talking about dirty and clean urines, but rather talking about positive and negative results, the same we would do with any other area of medicine. Next slide. And that's it. I think I've been talking at you pretty fast for about a half an hour. And I appreciate you listening. Feel free to reach out to me if you have questions, want papers or any of this stuff. You can have these slides as well. Matthew, over to you, and Maddie, over to you.
Yeah, thank you so much. We will definitely share the slides. And if people have questions, please put them in the Q&A. But yes, let's turn things over to Matthew. Thank you so much.
Perfect. And Maddie, you can skip to slide. I think the first one kind of focused on next one and next. Great. So thank you, Dr. Kelly. And I do want to spend, save a few minutes at the end for questions and answers. So I'm going to go through really quickly about Shatterproof's initiative. And then really what I want to spend a little bit of time on today is talking about some of the actionable steps that you all can take in your community related to language change. Because I think, at least when I entered the field, I think, hearing presentations like Dr. Kelly's, obviously very persuasive when it comes to thinking about how can I change my, my own individual actions, but thinking of somebody who's trying to make that change in the community, how do you think of taking something like the dictionary or other resources and actually bringing it out to the public so you begin to see that change, in a wider way? And so one of the things, and I'll go through this portion fairly quickly, Shatterproof started looking at stigma, in a real way, really about 2 years ago, where we wanted to start, to understand all of the pieces that Dr. Kelly outlined, and really wanted to begin building resources in the space that were evidence-based and based on previous movement building as it relates to stigma reduction. And certainly there were pockets of this work happening, Dr. Kelly and his team being one of those, but we didn't necessarily see the same level of sort of national coordination that we saw in other movements, certainly when it comes to resources and resource allocation. Next slide. So one of the things that we were able to identify through all of this research was a few sort of core tenets and themes that came across in a lot of other social change movements. And a lot of this, by the way, is sort of reflected in the Life Unites Us campaign and probably mimics a lot of what Dr. Kelly recently shared. I think the key component here that we're going to be talking about today is number 2, right? That whether it is marriage equality or HIV/AIDS or tobacco, et cetera, language change played a big portion in, changing perceptions for those previous movements. Even things like cancer, right, which now is not a disease that is considered stigmatized, was heavily stigmatized in the 1930s, 1940s, and 1950s, and language, among many other changes, was one of the key components of how that stigma began to decrease. Next slide. Next slide. And next. So similar to the slide that Dr. Kelly shared earlier, there's 3 real categories that the Shatterproof team prioritizes: educate, language, and policy. And I think language being sort of the key component that we're going to discuss today. I couldn't agree more with some of the key points that were shared in the first 30 to 45 minutes of the presentation. This is complicated, and I think that there is a lot of nuance when you get down to particular words and how they impact people's perception. But I think there's no doubt from the literature that the way that we communicate about these topics in our communities has a really profound effect on the perception and the stigma. A lot of which is what this this project and all the people who are on this call are so dedicated to reducing. Next slide. So, I'm really excited today to talk about some of the resources that Shatterproof is about to distribute. All of these will be disseminated within the next 3 or 4 weeks, but you can reach out to me at endstigma@shatterproof.org if you want any of these resources, ahead of time. And I can actually put this in the chat right now. So feel free to reach out, but really a lot of the resources that we focused on, we're trying to build quick, easy things that you can use in your community that are evidence-based, that are based on the latest research, and that don't necessarily require a super deep dive. So I think, the benefit of something like the Addictionary or Shatterproof's own addiction language guide is that it can get into really good depth and show a lot of the nuance in the research around these topics and words. The challenge is that when you're all out in your communities and when you're talking with partners and the people that you're working with, a PDF with multiple pages may not be the right thing or piece of information to disseminate to them. And so we built a lot of additional resources that we're excited about that will solve some of those outreach problems. Of course, we have built our own language guide based on the existing research. Next slide. And what we wanted to do was really spell out for other journalists, healthcare providers, community organizations, people leading, RCOs, et cetera, what the language is, what the recommended language is, what stigmatizing language exists. And then we also wanted to include in the language guide the existing rationale or related research related to those particular language changes. At least from my personal experience, when you're out in the field or when you're talking with people, you can oftentimes recommend why language should be changed, but there's a lot of skepticism. They might say, hey, I've heard, anecdotally, this person in my community say this word, so why is it bad for me to say it as well? And I think having all of these resources and some of the corresponding research, including the components that Dr. Kelly shared, is really important as you're making that push and doing that advocacy. Next slide. And then included in the language guide is a very detailed list of all of the other resources available, including the Addictionary that are out there related to language change. Many of these have slightly different flavors. They're slightly different lengths. They're all really excellent. And the vast majority of them include the latest research on the topic. And so as you're thinking about, being out there and picking resources that work for your community, for your local jurisdiction, it might be important to scan through some of these resources as well to see what works best for you. Next slide. In addition to the language guide, we've also built some interactive lessons and some shorter materials that may be more engaging on things like social media or in your email channels than a PDF document. I certainly wouldn't necessarily recommend these shorter videos or clips when you're trying to really do deep change, right? When you're trying to create change with journalists or other people who use a lot of different vernacular as it relates to addiction. In that case, something like the dictionary or the language guide that provides a lot more detail may be better. But this video lesson, which will be released in the next 2 or 3 weeks, it's about 2 minutes long, perfect to share, via social media, covers a few of the key words, things like quote unquote abuse, and addict, and also talks about the words to replace them with. And I think it's just a really nice, engaging, piece of content as you go out into your community. And this will be freely available on our website for distribution. Next slide. In addition, we're also creating some social media assets that folks can use related to language. As Dr. Kelly said, story sharing is really critical. And what we've been able to do with some of our partners is build out, story sharing content that is mixed in with key lessons around language. And we think this may have a, dual purpose of both reducing stigma because you're engaging with someone's story, but also playing an educational role of, educating about how language could be shifted, and what words to use and which words not to use. Next slide. And the last thing I'll say here, and this is another one of our graphics that I think is really crucial as you're going out there, and this is one of the things that Shatterproof has spent a lot of time on, is figuring out how to create space with those who are in recovery or those with substance use disorders to reclaim certain words while also making it clear who can and cannot say those words, right? And so, well, I think, broadly speaking, because of, the effect that words has on the general populace and perceptions, people should be moving in the direction of using words like people with a substance use disorder or recovery or misuse. But it's also important that we, don't preach to those who are in recovery on exactly the words that they're trying to reclaim or use for themselves. And so making this distinction, though, I think as an advocacy organization is so critical, because, 9 times out of 10, when I talk with, maybe not 9 times out of 10, but very frequently, when I speak with other clinicians or when I speak with other community, organizers who do use stigmatizing words, one of the examples that they use of why they're using those words is because they're hearing it from those who are in recovery or, presenting with an SUD themselves. And so, I think this nuance is really important, and I just wanted to, share it before we end it. But I think that's the majority of the information that I have for everybody today. Like I said, we have these resources and others that are available for people as they want to actualize some of these changes in their own, local community. And you can reach out to us at that email, and we can get those resources over to you when they're released.
Thank you, Matthew. This is really great. Do we have any questions from the participants? Feel free to drop a question into the Q&A box, or you can type it into the chat box as well. And Matthew's contact is up on the screen now if anyone has questions. Okay, we have a first question here. What about using the word addiction instead of substance use disorder? Is that problematic? Matthew, any thoughts on, or John, Dr. Kelly, any thoughts there?
Do you want me to go first there, Matthew?
You go first. Yeah.
Well, yes. Well, addiction is a particular construct. It depends on, I think we all use addiction as a kind of a generic term to capture and cover the whole spectrum of substance-related problems. That in itself, of course, not too much wrong with that, but the actual addiction, the true definition, technical term of addiction is, it would be synonymous with a severe substance use disorder. Substance use disorder is not addiction, but it encompasses addiction. So the severe end of that spectrum encompasses addiction, the addiction syndrome, which is a more severe form of substance use disorder. But you have kind of mild and moderate forms, which may lead to addiction, some may not. They're just qualitatively distinct subtypes. Some may not ever become addicted, even though they may be involved with the substance, using it, and maybe harming themselves or others by it. But there's nothing, I don't think there's anything wrong with that term addiction per se in terms of stigma.
Yeah, and I think the you know, when you look at the language guide and you look at sort of the vast majority of the words that I think that we're finding that you know, are proven out as stigmatizing are the ones where you're you know, and this gets to sort of the person first language, when you're actually replacing the person with the thing that they are, which I think is naturally a bit, I mean, just by the way the word is set up, more difficult to do with addiction as a word. You know, when I have conversations with others, I think it's, you know, probably best practice to you know, tend towards, you know, substance use disorder, just because then as you're talking about people with substance use disorder versus person with an addiction. You know, I think naturally it's just more difficult to incorporate addiction into, you know, your conversation or dialogue in a way that does a lot of the problematic sort of blaming and turning the person into their own disease that I think is at the root of a lot of the other words that we talk about, like quote unquote addict or junkie, where that person actually becomes those things. Whereas addiction is sort of a, like Dr. Kelly said, sort of a separate construct that's hard to attach in the same way.
Yeah, that's really a helpful answer. Another question from the chat box: where do you feel like family members fall in this language? So I think that's probably in reference to that Venn diagram that you showed with the different terminology. So where would family members fall in that?
Yeah, I mean, my personal opinion is definitely in the middle, right? I mean, I think you know, generally speaking, even for those who are in recovery, I think because of what we know from Dr. Kelly's research and others, it's better, you know, in terms of the perception to be talking about person with a substance use disorder or misuse, et cetera. But we've heard obviously from a lot of advocates and people in the community about their own individual choices to sort of reclaim that language. And so at least at Shatterproof, our personal, you know, we're never going to tell someone in recovery how they should define their own, you know, how they should define their own journey. And that said, I think it's really critical that family members who surround that person are using language that is not as stigmatizing and doesn't define, you know, them as their disease for everything that we said. I mean, for many of the studies that Dr. Kelly referenced about, you know, clinicians and how that creates certain environments or the perception, I think you can extrapolate that certainly to family members to some degree.
And I think it changes a bit over time, obviously, as well. People don't refer to themselves as drunks or inebriates or lunatics anymore. We don't have lunatic asylums. We don't call them that. We used to. That was common terminology 100 years ago. But our language evolves and changes, and it's a matter of time before even those in the recovery community will start to adopt and change. In probably 50 years, 100 years, we'll see those changes evolving as well.
That's great. Another great question: what's the best to correct yourself if you accidentally use the wrong word?
Hey, well, I'll tell you what. If you're aware of it, number one, right? If you actually become more aware, hopefully, of being exposed to presentations like this and materials like Matthew's providing and Shatterproof is providing, that's really great. So if you're becoming aware of it, you can just catch yourself and just say, well, excuse me, I should have said, you know, substance use or person first, use person first language. But I think that's just fantastic because, like I said, our language is habit, right? We don't think about, you know, our language becomes automated. And just like we say eating disorder, we don't think about it when we say that. We don't have to stop ourselves to think, am I using the right language? And over time, you just train yourself. 3 or 4 times you start to say it, it becomes automatic. Just like any habit that we acquire, you do it a number of times, it becomes automatic. So I'd say if you're aware of it, fantastic. You can always correct yourself, and in no time at all, you get used to saying it. I did it to myself, you know, because I had to train myself to use language that I was using, you know, kind of using that abuser terminology. When I go back to my very first paper that I published in in 20 years ago in 2000, I used abuser terminology in that paper, you know? So I was guilty myself of using that language, which I later came to really dislike and despise.
Yeah, and I think the other, this isn't a evidence-based piece of advice, but just as a human, in terms of how I've made some of those changes, but myself, I think the other thing too is certainly when you're joining webinars, any of them, or listening to calls or things like that, you're trying to pick up on that language too, and try to listen to it, because I think you'd be surprised, or maybe you wouldn't be, at how many people in the space, very progressive, forward-thinking people in the space, are still using negative terminology. And I think it's helpful, right? Even if you don't have an ability to correct them, or even if that's not really your role, but just to note it. And I think that's another really helpful way I've had of you start seeing how prevalent it is, and you also start seeing how connected, how that makes you feel about those people that they're describing. And then I think that naturally can help you see how you may want to change your own, language when you're presenting or speaking to community partners or people in recovery or whatever it may be.
Yeah.
Yeah, we are trying to change the names of the National Institutes of Health right now, get rid of the abuse terminology in NIDA and IIAA and SAMHSA. And I expect in this administration, the new administration, those things will change. Interestingly, Joe Biden wrote a bill to actually change the names of National Institutes of Health about 10 years ago. So it's likely that Joe Biden's administration would be in favor of getting rid of that abuse terminology at the top federal level, which is still embedded, right, in our national institutes.
Yeah, thank you. So I know we are at time here, but we do have a couple of extra questions. So for those who can stick around, we'll continue to answer a few questions here. And I'm dropping a survey link in the chat box for those of you who need to hop off early. We'd love to hear your feedback. But our next question is, so as much as we want to respect an individual's use of their own language for their own story, are there informative or psychoeducational methods to encourage people to use more compassionate or human first language on themselves without overstepping?
Well, I would say that through exposure, our culture changes over time. Our language habits change over time. Like I said, we don't use lunatic asylum, inebriates, drunkards, the way that we used to. That was common vernacular. But it takes time and exposure. As our language seeps into our culture and our cultural psyche, these things will gradually change. So I think exposure to these terms, I think if we have a top-down approach from the top levels of federal government, public health, national public health institutions, as those start to change, there'll be a disseminating effect throughout the population that will gradually change, and our language will change. And the way that people refer to themselves will also change, I think.
Yeah, and I think it's setting in context on all these things, like most of these sort of reforms or language change really matters, right? So when I say that Shatterproof isn't going to come out and do this, right? Like if I was on a panel with someone who's in recovery and they were saying it in front of 200 people, I wouldn't call them out and say, you should start defining, your language and talking about yourself differently. I think settings like that are obviously, inappropriate, and certainly reclaim some of that, claim some of that energy, agency that people are trying to reclaim. That said, there are times, I can give an example. We're building out a, library of stories of people who are in recovery, who are sharing, evidence-based messages similar to, what Life Unites Us is doing. And certainly if someone is sharing a lot of problematic language in their own story, we find a way to have a conversation with them and say, look, here's what the evidence says. The information that will be disseminated, across to a lot of people. And some folks, some folks say, hey, I didn't know that. That's news to me. And others say, hey, this is how I describe myself. I'm really proud of what I've been able to overcome, and I'm going to keep describing myself that way. So I think it's, but those are one-on-one conversations in a way where, you're providing facts. You're almost not even leading with suggestions. You're just saying, here's what I know about language, and choose to do what you want with it. I think if you're doing things like that, you can create a much better environment to slowly nudge that change versus making outright suggestions in more public forums or just in general.
That's great. Just a quick question for Matthew. Does Shatterproof have these resources in any other languages?
Great question. We're moving in that direction. So we're moving in that direction generally, nothing yet, but it's a great question. And I know it's something that's sort of high on our priority list for 2021. Certainly keep in touch if you want to reach out and add to the chorus of folks who are encouraging us to make more content in different languages. That would be great. And so feel free to email that link with your suggestions, and I'll make sure to take it to the team to see what we can continue to do.
Awesome. Okay, last question. So meeting people where they're at, isn't it best to refer to them in the way in which they refer to themselves, at least while working with them on changing their view on themselves? Any thoughts on that situation?
Yeah, I mean, I think one of the easiest ways that I've found to do that is just to stick with as much as you can, right? And I know this is not, possible in every setting, but when people are kind of deciding between these two words, I oftentimes just make the suggestion of just referring to them as their name or their, right? Like, rather than sort of defining either as a substance use disorder or addict or anything like that, just try to create that personal connection. I obviously don't know the certain context that this person's asking the question within. So in some ways that can obviously be challenging. But if there is that confusion, generally I think it's better to not use the words. And if you can, if you can focus on an individual, their name and their background and things like that versus using the negative terminology, I think that's best. I don't know, Dr. Kelly, if you have any, different thoughts.
Yeah, no, I think the question is a good one. It's a good comment in the sense that, we want to meet people where they're at, but we also don't want to re-stigmatize potentially the self-stigma that people have, interjected from society by modeling appropriate language, which it doesn't eradicate stigma, but it doesn't increase stigma, and it reduces stigma. So we can still be compassionate and be there and meet people where they're at, I think, but still model kind of appropriate language without losing connection. I don't think it's a matter of we wouldn't lose credibility or correction or connection. And at some point, if it's appropriate, I've had patients ask me, oh, why do you keep using that term? And I can explain it to them why I'd use that term and not another term. So I don't think we don't have to kind of use the same language or street language to connect with our patients.
Well, thank you all so much for being here and for taking all these questions. You have our email and contact information, so feel free to get in touch with more questions that are not quite fully satisfied here. And the last thing, I have one more question for all of you, a second poll question on our next webinar. So we hope that you all will be able to join us again next month. But help us decide what the topic is by just completing this poll quickly. When we're thinking about recovery and the workplace, what topic are you most interested in? And then the slide on the screen right now is ways to get in touch with us, become a partner, follow, share, or share your own story. We'd love to be in touch with you and continue to work together. So thank you again to Dr. Kelly and Matthew for joining us today. And we hope to see you all on the internet and in person again someday soon. Thank you so much, everyone.
Thanks, Maddie.